Hi, and welcome to Microbiome Lab's Clinical Grand Rounds. I'm Dr. Nicole Berkins, and for today's session, we have Kiran Krishnan here to discuss ACE2 receptors, underlying inflammation, and how this all connects to the COVID-19 situation we're currently facing. Kiran is a research microbiologist and has been involved in the dietary supplement and nutrition market for the past 18 years. He comes from a strict research background, having spent several years with hands-on research and development in the fields of molecular medicine and microbiology at the University of Iowa. Kiran established a clinical research organization where he designed and conducted dozens of human clinical trials in human nutrition. He is co-founder and chief scientific officer at Microbiome Labs and has developed over 50 private label nutritional products throughout his career. He's a frequent lecturer on the human microbiome at medical and nutrition conferences, conducts a very popular microbiome series educational webinar, is an expert guest on national and satellite radio, has appeared in several international documentaries, and has been a guest speaker on several international health summits as a microbiome expert. He's currently involved in 10 novel human clinical trials on probiotics and the human microbiome. Kiran, thank you for being with us today.
Of course, it's my pleasure. Thank you for having me.
So we have this situation that we're all currently experiencing and living through with coronavirus, this COVID-19 situation. To say that it has certainly turned the world upside down is no exaggeration on a personal, professional, global kind of level. Yeah. And, you know, when you and I were talking about what to cover for this clinical grand rounds this month, it really felt like it made sense to cover some nuts and bolts related to this and give our practitioner community some ways to understand how these pieces fit together and even some practical common sense things that we can be doing to support patients during this time. So I'm going to really let you dive into, you have been looking at a lot of the research, a lot of the data and things coming out. What are some of the big picture things that we need to be thinking about and aware of in terms of our clients and our patients and this virus?
Yeah, you know, what's so interesting is when you look at the disease pathology of COVID-19, and if you look at the virus, how it's evolved, what its targets are, who are the most susceptible not only to infection, but also to a really adverse response to the infection, it really kind of comes back to what the functional medicine world has been focusing on. You know, so I think the functional medicine world and every functional medicine practitioner that's listening to this plays a critical role in helping their patients improve their resilience to pathogens like this, which is also the same resilience that you're trying to build to ward off chronic illness. This virus has very smartly evolved to target a receptor that indicates weakness in a system, right? And so that's where we've kind of delved into this and gone, okay, this is a really interesting scenario. As devastating as it is in many, many ways, there is some silver lining here because it illuminates certain vulnerabilities that we have as a society. And that's one of the things that concerned me, because when we started seeing the data coming out of Asia, where it all first started, it seemed to be clearly an elderly person issue, right? If you were over 65, your risk was pretty high. If you were over 75, it was even higher, and that younger people, for the most part, spared, or had very mild or could even be asymptomatic. And then as the disease starts moving west, when it started hitting Europe, we started seeing a change in the demographic. And then now in places like New York and most of the US, we're seeing a larger portion of the younger population getting sick and also being part of that group that needs hospitalization and care in the hospital. I think some of the latest CDC data is around 50% or so of all of the total infections are in people between 18 and 49, in the US. And so we're seeing a large chunk of the sick people being the younger population. In New York, recently they showed 26% of those that are hospitalized in more of that intensive care setting are people between the ages of 18 and 44. So a quarter of the people are the young people. So what's happening there, and it really kind of illuminates how important this whole world of functional medicine practice is, because we've been talking about root cause issues. and there's a root cause component to this as well. So, we should jump in and talk about the ACE and ACE2 receptor,
Yeah.
right?
Yeah, because really what you're talking about is this whole principle of inflammation being such a driving factor for not only so many specific diseases and illnesses, but also for reducing a person's physical resilience to, being able to fight off things like viruses and those kinds of illnesses. And certainly it's an excellent point when we look at, a place like China compared to here, different diets, different lifestyle, different everything. And so it's interesting to think about how what we've all been speaking about now for years and years about how sort of our Western culture, Western diet is promoting inflammation, making people more susceptible, how that now is intersecting with a virus like this and making us more susceptible to this kind of stuff.
Yeah, and it's scary because in the U.S. population, I mean, we've got about 50% of the population has at least one chronic illness, right? And that chronic illness is typically, some form of metabolic syndrome or autoimmune disease or cancer or degenerative conditions like Alzheimer's, Parkinson's, all of which are underscored by the chronic low-grade inflammation that is driving those conditions. So we've got a large portion of our population that actually is vulnerable and at risk when it comes to something like this. So let's talk a little bit about that mechanism.
Yes.
And people are going to be hearing a lot about this ACE2 receptor, and the vast majority of people have probably never heard of that before. Right. And then when you start digging into the research, it can seem a little confusing because there are lots of terms that are interchangeable within the jargon associated with the ACE and RAS system. So I'm going to attempt to kind of clarify all that and kind of make it more practical and understandable. So what ACE is, so there's ACE and ACE2. ACE is angiotensin converting enzyme. So there's the original angiotensin converting enzyme that they've known about for several decades now. And then over, I think 15 years ago, 20 years ago, they discovered a second one called ACE2. They're both angiotensin converting enzymes. They are transmembrane enzymes, which is interesting. So a lot of enzymes in your body are floating around and they find their substrates and they conduct their enzymatic activity. This is a transmembrane enzyme, so it's stuck on a cell on the membrane, and it's expressed by the cell based on different stimuli. So what's happening here is that anytime there's tissue damage inside the body, and this is on the vascular endothelium, this is in your gut epithelium, this is on the lungs, on the cardiac muscle, on the smooth muscle cells. So any of the cells and tissues that line the inside of the body are designed to have a repair mechanism should there be damage to that tissue, right? It's no different than the scarring that occurs on our epidermis if we cut our skin, or if we cut our palm. Any of these areas, they have scarring and tissue remodeling mechanisms that come in and do the repair. So the RAS system, the renin-angiotensin-aldosterone system, is the repair mechanism for the inside part of the body. So let's imagine somebody has high blood pressure. One of the consequences of high blood pressure is more abrasive action of blood on the endothelium of the vessels, right? So then you get, especially at the arterial bifurcations where you see the bifurcation and you have that valley there, the blood actually comes and slams there at a higher viscosity and then spreads into the different channels. Those areas tend to get damaged quite a bit just by the abrasive force of the blood. Now, every time there's damage there, then the RAS system gets triggered to come in and repair that area. What the RAS system does is it creates vasoconstriction, so it kind of tightens up the space. It recruits inflammatory cells because it's trying to ward off and quarantine that space, which is one of the jobs of inflammation. No different than if we cut our hand, we're going to get inflammation around that cut. Thus all the redness and tenderness. So it's going to recruit inflammation, and then it's going to recruit tissue remodeling cells that start remodeling the tissue and then creating fibrosis as well. And the fibrosis is a lattice which it's setting up for repair. The problem is if that continues to happen, which the damage continues to happen in the case of high blood pressure or in the case of diabetes where people have high blood sugar, which damages the endothelium and also damages it through things like glycation, there are biochemical reasons for the damage of the lining. That continuous damage continuously turns on this repair mechanism, and we get this over repair, if you will, and that tissue loses its compliance and function. The best example of that is in the heart, right? In the ventricles of the heart, every time the heart has to work really hard because of high blood pressure, high blood sugar, and so on, you get damage on the inside of the ventricles of the heart. You get oxidative stress damage to the actual muscles in the ventricles of the heart. And then it turns on the RAS system, and what you start to see is hypertrophy of the muscles that make up the contractile force of the ventricles of the heart. So over time, you get this cardiac hypertrophy, and that hypertrophy shrinks the size of the chambers in the ventricles. And then that, of course, shrinks the compliance of the heart. Your heart can no longer pump and be flexible and compliant. That's why they develop ACE inhibitors. The whole idea behind ACE inhibitors is that if we keep repairing the vessels that are getting damaged, if we keep repairing the heart muscle that's getting damaged, we lose compliance of these tissues. The vessels become stiff and non-compliant because they're fibrotic now and they can't expand, right? So then their compliance becomes smaller and smaller and smaller, and they can no longer expand to meet demand. The same thing with the heart muscle. It becomes thicker and thicker and thicker, and it no longer can expand. Same thing in the lung. You get what they call fibrosis and thickening of the basement membrane. So the membranes around the alveoli that are constantly being damaged because of smoking and hyperactivity of the immune system because of asthma and other immunological conditions. You get thickening around the alveoli, and that loses the compliance of the alveoli. It can no longer expand in order to fill up with air. So there is a protective mechanism around that happening, and that protective mechanism turns out to be ACE2. So ACE1 does all of that repair, and because there's chronic damage, ACE1 is chronically turned on and is chronically refixing all these tissues. Of course, the problem is that then loses the functionality of the tissue over time. ACE inhibitors have been designed to inhibit ACE1 so that that repair mechanism doesn't go on for too long. But then they discovered that there is a second mechanism called ACE2, which is competing against ACE1. So the body is smart enough to know that, hey, if we start repairing, we also need to stop the repair at some point and reestablish compliance and functionality of the systems. So ACE2 does exactly the opposite. It actually inhibits ACE1 by competing for angiotensin, which is the active peptide that both enzymes catalyze. And then it actually does the opposite. It actually increases blood flow. It improves compliance. It stops fibrosis. It is very anti-inflammatory, so it reduces the inflammatory response. It turns down the inflammatory cytokine response in those tissues, and it's trying to reestablish compliance and function, right? So these two things work antagonistically. So that's the basic premise, but as it turns out, both of these should be acute things, right? We're not supposed to be having continuous damage to internal tissue. Just like on your palm of your hand, if you work outside, work with your hands a lot, the continuous damage leads to callousing of the palm, and that tissue looks different than the rest of your skin. That same callousing is happening on the inside, and so these two systems are being continuously triggered. ACE1 is continuously triggered by damage. ACE2 has to be continuously triggered to try to counteract the damage. So as it turns out, the chronic expression of ACE2 and the expression of ACE2 in lots of tissues, because it's a pretty ubiquitous receptor, that expression indicates that that person's constitution is weak. Right? Even though ACE2 in itself, and as you start reading this, I've had a lot of people send me messages and go, wait a minute, ACE2 is good. It's a good thing. I'm confused. It is a good thing. It's the anti-inflammatory, the anti-fibrotic portion of the system, but its continuous expression indicates that that individual is weakened and has a weakened state. And if you think about the genius of evolution, this virus, which is trying to find the weakest in our herds, because the virus has to take over our machinery and hope to evade our immune system response, it's found its sole trigger being this receptor, which if it's expressed in lots of tissue, indicates that that host is weak. right? Because that host has continuous damage going on and continuously needs to express this receptor to undo the damage. So it's really telling of what's going on in our society, and I'm glad, one of the silver linings is it's bringing awareness to this whole mechanism. And one of the things we've been talking about, is that chronic low-grade inflammation, the gut being a major source of that. And we started digging into studies and finding out that, hey, there is a significant tie between chronic LPS elevations in the serum and the expression of ACE2. One of the major ways our body tries to undo damage by LPS, which is a lipopolysaccharide that leaks in from the lumen of the intestine into the circulatory system through a permeable intestinal lining. One of the ways that the body defends against that is by increasing the expression of ACE2. So there are all of these studies that show that ACE2 negates the inflammatory damage that LPS causes. And so if you've got lots of LPS leaking in at a high level, then you've got lots of ACE2 expression going on all the time, which then makes one more vulnerable for these types of pathogens. Right. So
that it's such an important mechanism to understand, because as papers are coming out now, a lot of it hypothesizing at this point, right? Because we're still early in the process of understanding this, but what they're finding and hypothesizing is that the more ACE2 receptors, the more that is activated, the more prevalent that is, the easier it is for the virus to invade the person, attack the immune system, and create problems, right? So people with these chronic underlying inflammatory conditions who have a lot more of this ACE2 activation are, at least theoretically, going to be more predisposed to having more significant problems as a result of getting this virus.
Yeah, absolutely. And, the health authorities have correctly identified that people who have heart disease, people who are diabetic, who have, respiratory conditions like COPD or asthma, are at higher risk. Hypertension are at higher risk because a lot of those types of conditions are driving continuous damage to the endothelial, epithelial, and smooth muscle tissue inside the body, and those are all likely associated with higher expression of ACE2. But I think one of the areas that actually creates even more risk for us for a different set of the population that doesn't fall under the diabetic, hypertensive, heart disease yet are the people with severe endotoxemia with high levels of LPS, right? Yeah. One of the things that was really troubling to me when I first started looking into this was remembering that in our 2017 study on leaky gut and endotoxemia, we were screening healthy young college students, right? So these are healthy young by all FDA and other standards, meaning they had no chronic illness. They weren't on any medications or anything. They didn't present with any sort of health condition or what would be considered in this case risk factors. They were not obese. They were, young, vibrant, healthy people. And 55% of them had huge increase in LPS in the serum after eating a meal. Yeah. Right. And that LPS was also triggering a huge upregulation of inflammatory cytokines in them. Mm-hmm. We saw all of that. Right. So even though you're not, you don't have heart disease, even though you're not diabetic or you're not hypertensive, or you're not under the COPD or other pulmonary dysfunctions, we have a population of young individuals that have chronic inflammation from endotoxemia. Mm-hmm. So the risks are there. Again, we don't know, we don't have the data to show that they are, getting higher rates of infection of COVID-19 or any of that stuff. This is all, just speculation or hypothesis, but it begs us to think about this a little bit more because this virus is illuminating a vulnerability in our population.
It's such an interesting point because we do know that so many people have, when they end up with such significant symptoms that they're in a practitioner's office, when you take a history and look back very often, almost 100% of the time, you see this history of things that was trending in that direction, right? So I think that's the piece of it, even at younger ages, kids, teens, people in their 20s, even their 30s, they may not have these huge blaring, symptoms of chronic disease yet, but it's brewing. And that's, to your point with that study, even after eating, that leaky gut then is obvious and it's there. And the endotoxemia from that and how that lays the foundation for probably getting diagnosed at some point later on with some sort of chronic disease. But it really begs the question then of, because we don't have treatments yet for this, right? I mean, we don't have anything that we know addresses this. So it really leaves us with looking at what makes sense based on these hypotheses, based on understanding, what physiologically is going on, as you just described it, what makes sense for us to do and to have patients and clients think about doing.
Yeah. So that to me is the most important question now, because until there is some sort of cure or treatment for this, which we don't have right now, and the best, in my view, that we can do is improve our resilience and make ourselves less of a target for this particular pathogen, right? It's the estimates is that at some point, 50% or 60% of the population is going to come across this virus at some point, because it's not going away anytime soon. We may be able to flatten the curve, hopefully, if people are compliant about the social distancing and all that, but it will remain in our population for the foreseeable future, which means most of us will come in contact with it at some point. And if we come in contact with it at some point, what is the constitution that we have at that moment? And what are the risks that constitution affords us at that point as our system is encountering the virus? So there's a couple of things that we know is that it targets the ACE2 receptor. So anything we can do to reduce systemic inflammation, which will hopefully reduce the expression of the ACE2 receptor, may then reduce the number of targets that the virus has to enter our cells and create replication within our system, right? And now it's clear that can occur in many different tissues. It's not just in the respiratory tract. It starts in 50% of the cases in the gut, where the American Journal of Gastroenterology published a study that said 50% of the COVID-19 patients present first with GI symptoms, diarrhea, cramping, loose stool, discomfort in the gut, nausea, vomiting, so this entire GI tract is lined with endothelial cells that can express ACE2 receptors in response to tissue damage. And we know that tissue damage is occurring all the time in the gut, right? Because of leaky gut and the inflammation and the dysfunction in the mucosa and so on. Those are things we've all talked about endlessly in the functional medicine space over the last several years. So that becomes a real risk that we need to pay attention to. So in terms of what people can do, to me, it's continuing the basics of functional medicine. It's the right probiotics, the right prebiotics, the right anti-inflammatory compounds that we've been using, the whole food diets, the fasting, the mindfulness work. All of those things are still on the table because at best what we can do is improve our resilience. And to me, one of the easy things to focus on is how do we stop that LPS from translocating, right? Because we definitely don't need that in addition to everything else going on, right? We definitely need to seal up the gut lining. We don't need that additional wave of inflammation that comes from the gut and from LPS endotoxemia. So the spores that we've been working with become an important tool as part of your maintenance and part of your increasing your resilience. The other tools that are being used at higher rates now, we're seeing that with our clients, is the IgG, the immunoglobulin product. The IgG, obviously, we're not making any inference that it binds or treats in any way COVID-19, but it does take a load off in the rest of your intestine because it does. There are studies showing that it can help with other pathogens that are going on that may be present in your system. And we're still in the cold and flu season, so we have other pathogens to worry about that could weaken the system, right? So the spores and the IgG play a really important role right now in assuring a little bit of increase in our resilience. The other thing that I've been upping my dose on and recommending to everybody else I talk to is the omega fatty acid, we created this product called Mega Omega, which has high levels of EPA, high levels of DPA, and then these PRMs, these pre-resolving mediators. The whole focus of that product is to counteract the arachidonic acid pathway that leads to significant inflammation in the lining of the gut tissue. Because what we came to find out is we've got the leaky gut type of inflammation driven by interleukin 6, driven by interferon gamma, so it's more of an immunological inflammation. And then we've got the physical inflammation from damage to the lining that's driven by arachidonic acid and the lipooxygenase, cyclooxygenase pathway. Through the probiotics and IgG and all that, we are supporting and addressing this area, but we may not be supporting and addressing this area, this type of inflammatory pathway enough. And so we started researching what does that and what shows counteracting this whole pathway, and omega fatty acids are the key, but it's EPA, not so much DPA.
Right.
I'm sorry, not so much DHA.
Yeah.
Yep. It's EPA, and then DPA does increase the absorption and functionality of EPA. And then PRMs, these pre-resolving mediators, these are intermediates of the resolution from EPA all the way down to the cellular anti-inflammatory fatty acids. So there are intermediate resolving compounds that actually stoke the anti-inflammatory process much faster than EPA itself can. So it becomes a really important compound to slow down the inflammatory damage going on in the gut lining. So, what we're trying to do is just kind of push and hedge our bets towards making ourselves more resilient and reducing all the sources of chronic inflammation in the body, because then that hopefully will reduce the target-rich environment that the virus has in many people.
Well, and, we're talking specifically about what's going on right now with, COVID-19, but to your point that you made earlier about evolution of, microorganisms, pathogens, they're smart. I mean, you and I talk about this all the time, how underappreciated these little, microbes, these little microorganisms are, but look at, little virus is taking down the world right now, has literally stopped everything. They're smart. They evolve in ways to, as you said, to take advantage of weaknesses in the system. This conversation isn't just about COVID-19. This is about the next one coming down the pike and the next one, because there's going to be others, whether they're other types of coronaviruses or, other types of pathogens. They're going to continue to evolve. We're going to be facing these. And so these concepts to understand about what makes our bodies more or less resilient and the things that we can be doing to support resilience are really, really important, not just specific to this virus, but really to this whole realm of things that we're going to continue to encounter.
Yeah, absolutely. And in between the pandemics, the same pathophysiology is driving all the chronic illness. It's driving all the autoimmune disease and metabolic syndrome and cognitive dysfunctions and neurodegenerative diseases and so on, right? So it's all the same stuff. It's all the same vulnerabilities that cause health dysfunctions and distress. And so now with this being at the forefront of everyone's mind because of the pandemic we're in, it's a great time to recognize the importance of maintaining resilience and bringing down those inflammatory sources, because it can be very relevant to the pandemic itself. But then hopefully that awareness stays once this pandemic is gone, because that same awareness is going to help us with all the other chronic illnesses we face. And so my encouragement to the functional medicine practitioners that have been working in this space for some time is to contact your patients and talk about how important it is, especially in the context of what's going on, what you've been doing for them. The vast majority of functional medicine practitioners are dealing with chronic low-grade inflammation and trying to curb that in many different ways, through lifestyle changes, through mindfulness work, through dietary changes, which are all extremely powerful to curb that risk. And then even utilizing products like we have, like the Megaspore, the IgG, the Mega Omega. Those things are tools in your toolkit that help with this same vulnerability. And that vulnerability is especially important now. So, it's unfortunate that a lot of practitioners that we know have had to close up clinics because they're not seeing patients in person. But I would encourage you to still contact your patients, whether it's email or phone or telemedicine, which a lot of people are adapting to. And all of the things that you've been talking about and doing for your patients are still absolutely relevant and absolutely important, and in some ways maybe the most important thing until there's an actual cure for this.
That's great advice for our practitioner community, because that is a simple thing to do, to reach out even if you're not seeing people directly right now, and make sure that they have this education piece of, hey, all these things we've been doing are helpful to this current situation. And that increases compliance too. If people are more prone to maybe falling off their protocols right now or whatever because they're not seeing their clinician regularly, that helps ensure compliance during this time. So I think that's a fabulous, very practical suggestion for our practitioner community, for sure.
Yeah, and a lot of our practitioners have amazing patients that are very health conscious. But this is also the time to get those patients to advocate for the people around them, right? Because they all have people, whether it's a spouse or a partner or a child or in-law or a mother, that doesn't really pay attention to this kind of stuff. And they've been talking to them, as advocates, going, hey, you really need to think about your gut health or your immune health. This is a great time for them to really bring those people into the health fold and go, all right, all we can do right now is improve our resilience, right? We don't have a treatment for this. We don't have a cure for this, but it becomes important to improve your resilience. Now, let me tell you about what my doctor has been talking to me about, with my gut health and immune health and so on. So, I think through kind of that network, we can improve the health and wellness of more people. And when we come out of this, maybe we come out of this healthier, stronger, smarter about everything that's going on. That's a potential silver lining from all of this devastation.
Well, and that would be a great silver lining, and really we need to look for those silver linings, and that could, absolutely be one. And I'm seeing that shift with patients as well, of really focusing on this and thinking about this resilience. So we're left with social distancing and building internal resilience, maybe are two of the keys to dealing with this, right?
Yeah, that's all we have right now.
That's right.
Yeah.
That's right. This has been a really helpful conversation. I know that practitioners are going to really benefit from this, some really practical strategies. So thank you so much for taking the time to do this today.
Thank you. My pleasure.
And thanks to all of you. We'll see you back here next month for our next Clinical Grand Round session. Take care.